we had a question that came up quite a bit today. One of our listeners said she was told that ADHD doesn't come on later in life. It should have been diagnosed earlier. Is it possible for menopause symptoms to make ADHD more apparent, so that she's no longer able to compensate? Is it possible that you could be diagnosed with ADHD in your 50s or beyond?
Absolutely. That is a great question and a very, very important question, I would say. And that is actually not at all uncommon. So what we see in our research is that women go undetected, missed or undiagnosed, sometimes for an entire lifetime. And when you are coping, when you are masking, and when you're trying to find strategies, and when you are functioning on top of your cognitive abilities every day, you may do that for periods when the life is calm and when you are in control. But then we see that in the periods of the reproductive life, where around puberty, around pregnancy and postpartum, and around perimenopause, is when a lot of women actually come to healthcare services asking, could this be ADHD? Because their compensatory strategies just doesn't hold up anymore.
Very helpful. And a number of listeners are weighing in the chat here to say that they were diagnosed at 42, 47, 50, 57, and beyond. So we see and that again, in our...
Just to emphasize that what we talked about earlier, the importance of doing this longitudinal exploration of life, because if you have no symptoms whatsoever during your life, and then you start having these symptoms around perimenopause, we probably should suspect that this is menopausal related. The overlap with ADHD symptoms is so big that and women may have masked and may have actually struggled with this, but we have to go back and we have to see, so were there symptoms, but you were able to mask them, or you were able to compensate for them?
Mm-hmm. So I wondered if we could just take a step back. You talked a good deal about it in your presentation, but to really clear up who should not be taking hormone replacement therapy based on the research that we understand today to be accurate.
Yeah, we have to take a step back, I think, to understand why healthcare professionals still today are not recommending hormonal therapy on a broader level. Because what happened was that there was a huge study, Women's Health Initiative study, that came out. When the results came out, it showed that women who were prescribed or treated with a certain kind of hormonal treatment had an increased risk for adverse health outcomes. And that was the truth for many, many, many years. And women during these years were then not treated. Almost the vast majority of women was not offered perimenopausal hormonal treatment. Then another research group started to looking at the data and seeing that there was some serious misunderstanding of the interpretation of the data. First of all, it was a very specific form of estrogen that was used, manufactured or derived from horse urine. So it was a completely different form of estrogen that is used today. But more importantly, the researcher doing this study had not corrected for the age of when the estrogen was introduced, or the hormones were introduced. So they were just giving all the women included in the study hormone replacement therapy. So it could have been like 10 years after your actual menopause, and then being introduced to hormones when you've already transitioned through perimenopause and you've been post-menopausal for a couple of years, that may be a health risk. However, there's a very beautiful window of opportunity when we're experiencing the hormonal symptoms of perimenopause and the years around menopause, where we today can see that the benefits outweigh the potential risks, and that the risks are primarily associated to certain women who have had hormonal dependent breast cancer or have heritable factors for breast cancer, or some certain complications to diabetes, for example. But the group that was not eligible for treatment 10, 20 years ago have now decreased to an individual assessment for every woman, and there is really and as I said, and there are also always the option of local estrogen treatment.
We have a surprising number of listeners today who say they are not members of any of those high-risk groups, and yet they've been told that they cannot begin hormone replacement therapy if they are still menstruating.
So there are a lot of there are I am not a gynecologist. I have to just put out in that disclaimer, but I work together and we see these patients together, and so what we tend to do then is you can, if you have, you always treat the symptoms, and that's the beautiful thing of being a doctor in this context, because you actually it's very clinical, hands-on work. So if you have perimenopausal symptoms, you can treat with hormonal treatment. You have to protect with the progesterone to make sure that when you treat with estrogen, you also add the progesterone. So it's always if you have your uterus intact, you need to also add the progesterone. If you are certain that you ovulate and that you still menstruate, and that with every menstruation you also ovulate, then in theory you can wait a little bit with introducing progesterones, but it is very, very, very difficult. In real practice, it's very difficult to know if it's actually been an ovulation before the bleeding, or if it can also be an unovulatory bleeding. Mm-hmm. So in medical practice, then what we do is that we treat with cyclic progesterones anyway, to be sure.
Okay. And you mentioned sort of the beautiful window where hormone replacement therapy would be most beneficial. What is as close as can be described, that beautiful window?
No, so I would say when you start having symptoms, mm-hmm. And then when you enter menopause, and menopause is a very tricky, that is a very tricky situation, right? Because that is something that we diagnose that we identify retrospectively. So menopause is actually 1 year after that you had your last period, right? So what most recommendations are that you could stay on the hormonal therapy for 5 years post menopause, but these guidelines are also constantly being updated with new research coming. So again, as I said, make sure to keep yourself updated every year, because there is a lot of research coming out now, and there is a lot of knowledge that is actually being gained at the moment.
Okay, very helpful. Yes, quite a few listeners as well wondering about the role of HRT in post-menopausal ADHD management. So it sounds like the research there is still...
So again, there's no research specifically on women with ADHD, but knowing that women with ADHD are already challenged in so many of these areas where we identify the post-menopausal symptoms, then what we see in our clinic is that women are more challenged by hormonal fluctuations. Women with ADHD more challenged by hormonal fluctuations. What we see, but what we have not yet explored and proven in our research, is that it seems like women with ADHD also experience perimenopausal symptoms at an earlier age. So perhaps our hypothesis is that this perimenopausal period where you actually have increased symptoms may be prolonged for women with ADHD. So that maybe you come to your healthcare practitioner earlier asking about symptoms that we later on discover were actually associated to perimenopause.
Well, a number of people asking about that today. So that's very interesting. Yeah. Here was a great question. When I experience a symptom that could be caused by either ADHD or menopause, for example, migraines, irritability, emotional dysregulation, how do I know whether to make an appointment with my psychiatrist to adjust my ADHD medication or my gynecologist to adjust my HRT?
I wish that I did not have to answer that question, and that would not be an issue. That there were healthcare professionals that actually could have a holistic view of us women. But then that is an almost impossible question to answer. I would say probably. What is your own best guess, and start there. As I try to explain in these slides, there we don't want to start titrating up ADHD doses if there is a hormonal situation that could be tended to, and on the other hand, we don't want to miss out on titrating and changing the ADHD dose. So I will probably have to say that these two healthcare professionals need to discuss and talk to each other, because it's again you can feel like kind of left in the middle here as a woman, having to decide what symptoms you should go for and what healthcare professional you should consult, and that is unfortunate, of course.
It is. And along those lines, do we know anything today based on research about how menopause affects the efficacy of ADHD medication and or the safety of ADHD medication used in conjunction with hormone replacement therapy?
Yeah, great question. We know there's no evidence, there's no data. Well, but we know something, and we do have a lot of clinical experience here, and we know that dopamine and estrogen interact and modulate each other's effects. So what we hear from women is that when they enter perimenopause and when their estrogen levels on average are decreasing, that the efficacy of the medication also can decrease. And what we have seen, again, not proven in any studies, is that the effectiveness of the medication seems to be stronger in the follicular phase of the menstrual cycle, where estrogen levels are higher typically, and less effect in the luteal phase, where progesterone is the dominant hormone. So many women with women in middle-aged or older, where there is no research and there is no guidance for doses and for medication, still experience that when you tailor and when you adapt medication, the medication can be effective and safe for women over 50 or 65, where the research is really, really thin.